we do see is where things go wrong, it's sometimes that people who notice when something is not as it should be don't feel empowered to speak up. So one of the risks of a real hierarchical approach.
Today, we are joined by Andrew Murray, a GP and senior NHS leader with broad experience across primary care, system leadership, and acute hospitals. He is currently Vice Chair and Quality Committee Chair of a large NHS trust in London. His perspective spans the full spectrum from prevention and primary care through complex hospital provision.
It's hard to generate a culture of collective responsibility where every voice matters. It's a very hierarchical model where the consultant is the boss and carries that themselves. The non-doctor clinical leaders are always a little bit more up for working and leading together sometimes than the doctors are.
When there's clinical leadership working at the heart of the way things are done around, how can you tell it's really working?
That's a very broad question. I guess really effective leadership is about
Great to have Dr. Andrew Murray join me today. Today we're going to be concentrating particularly on clinical leadership and operating models in NHS organisations. Andrew is a GP and a senior NHS leader with lots of experience across the whole system, across primary care, system leadership, and indeed in acute hospitals. He's now vice chair of a big trust in London. And so his perspective will bring everything from prevention and primary care through to complex NHS hospital provision. And so it's in that context, we're really looking forward, Andrew, to hearing your views and perspectives about operating models in trust. So welcome. It's great to have you join us today.
Thank you.
So can we start off with a question that I think is always interesting when I start work in a trust, which is, what is an operating model? So if people talk about an operating model or a target operating model, how do you think most clinicians would respond to that?
Probably with a blank expression.
Right. Yeah.
I'm not sure it does mean much to folk who are actually doing the clinical jobs in hospitals. But I mean, essentially what an operating model is just the way you organise how you run the organisation and how you structure things. And I think what is meaningful for people is understanding in a leadership context what their responsibilities are, who they report to, and how they get stuff done. And often one of the challenges for people who want to make change in their own departments and their own context is the bureaucracy and the difficulty and the multiple layers that exist in big organizations to just try and get decisions made on things that seem quite simple and should be quite straightforward to get done. And I guess the essence of a good operating model is it clarifies and simplifies some of those processes, the reporting lines, the ways of making decisions in an organization.
Yeah, no, that makes lots of sense. That resonates with, I was talking to a senior clinician in a trust a couple of weeks ago, and she said they wanted to make a change based on value from a grommet that cost something like £17 to something that cost £18, and it took over a year to get sign off for it. It just, the way the decisions got made, or in fact didn't get made, didn't make any sense to the people in the organisation, and I think that just breeds frustration.
Well, if you don't get this right, you make it so difficult for people that they almost give up trying. And so without a good operating model, it can have an impact on quality of service, the motivation of your staff, their productivity, their efficiency, and ultimately the standard of care they can give to patients. So it sounds boring to frontline clinicians, and it sounds sometimes irrelevant to their daily lives, all this nebulous work on an operating model. When you describe it in terms of we're trying to create a way of working that makes it easy for you to make the changes you need to make for the good of your team, your department, to work more efficiently and ultimately to provide better care to patients, then actually people sit up and listen, I think.
Yeah, yeah, they absolutely. At the core of every trust operating model, we talk about the importance of kind of clinical leadership, and how does that need to work out? And in your experience, when there's clinical leadership working at the heart of the way things are done around here, what does that look like? How can you tell it's really working?
Well, I mean, that's a very broad question.
Sorry.
But so I'm thinking about where to start answering that. But I guess really effective leadership is about the impact you have on your followers, isn't it?
Yeah.
So how do you know when leadership is going well? It's how well the people who are being led are performing, how good their morale is, how positive they feel about the organization and the place they're working in, and ultimately then how well they do their jobs. Because the job of a leader is to get the best of the people that they're responsible for. When does it work really well? When you've got aligned multidisciplinary leadership, I think, because teams and departments are so dependent on colleagues around them. So I mean, if I think of maternity as an example, the interaction between midwives and doctors and all the other professionals who work in that context is so important that you need the leadership to be aligned as well. So it needs to feel like midwifery and doctor leadership are absolutely on the same page and are working together. And that can be difficult to do because of the way, partly because of the way doctors think and have been trained to think over time. In my experience, the non-doctor clinical leaders are always a little bit more up for working and leading together sometimes than the doctors are.
Yeah. But that critical, whether it's maternity and it's or perinatal services and it's a quad with midwifery, nursing, obstetric leadership and operations, or a triumvirate, which you often get in other services, that's a critical team for effective delivery at a service level in your experience. Is that right?
Yeah, I would say tries, quads, whatever. Basically, clinicians and managers working hand in hand together on
Yeah.
problem and on leadership of a department is absolutely critical. And I've seen it work well in organizations, and I've seen it work well at system. Unless they're having the conversations together about problems and solving it together, unless they agree together on what the priorities are for the department and the purpose, then it just sends mixed messages and people aren't clear about what's expected of them. When problems arise, blame is thrown around. And, what you need is people collectively to own problems and to see it as a problem that they have to solve together.
And you said that you felt like the medical part of that might sometimes be, if not a problem, it's harder almost for medics to participate in that multi-professional leadership. Do you want to say a bit more about why that is?
I think there's a couple of reasons why sometimes the tri or the quad doesn't work as effectively as it could. So sometimes it's difficult for the doctors to work in that joined up way. And I think sometimes it's a factor of time because of the
Yes.
leaders, and it's difficult for them to be part of all the conversations and to be in all the meetings. And I see that, and I understand why, because it's sometimes of the scheduling of their commitments. And I don't think we necessarily structure the job plans for doctor leaders in the most helpful, thoughtful way, and in a way that allows them to participate in all the key conversations and meetings that are so critical. I think the time also possibly sometimes impacts their ability to build those relationships and trust that you need to lead together. There's also something about doctors being trained very much to be experts in one particular field, and therefore feeling like they have the most up-to-date and specific knowledge about the area they're leading, which sometimes means that their ultimate view is probably that they know best about a particular problem or departmental issue or a service or how it needs to change. And I think one of the key things for all of us as leaders is to develop that humility to know that people who might not have the same level of knowledge about the medical condition might actually understand better than you some of the other issues that are going on for a service or in a department. And actually, as care is so holistic and multidisciplinary when it's at its best, actually all those perspectives are really critical to understanding what makes a service run well and what might be hindering it.
I think that makes lots of sense. I've seen all of that as well. I wonder if there's something in the nature, particularly in a hospital setting, where a consultant has accountability ultimately for the care of the patient, the decision making, and we know decision making about surgery, and then the execution is we can be really challenging, but you're so used to having that personal accountability when you're then in a different setting and it's a team accountability, as you say, with different perspectives. I don't know how easy it is for everybody to transfer across those different domains, the kind of different ways of decision making. I don't know if that's true, and if now care is so multi-professional anyway, that actually you're getting more used to that.
Well, the strengths and weaknesses of that approach, aren't there? There's the strength of having a sort of boss doctor who ultimately feels responsible for the care of a
Yeah.
particular patient is in some ways a good thing, because you want someone who's going to take real responsibility and make sure that everything goes as well as it can for that patient. But it's also a weakness if those working with you don't feel that same level of responsibility. And it's hard to generate a culture of collective responsibility where every voice matters if ultimately it's a very sort of hierarchical model where the consultant is the boss and carries that themselves. I think a model where there's shared responsibility and everyone feels that sense of responsibility, yet with real clarity around who makes decisions about what, then I think you can bring out the best of everyone in that context and deliver a safer service. Because what we do see is where things go wrong, it's sometimes that people who notice when something is not as it should be don't feel empowered to speak up. So one of the risks of a real hierarchical approach where the doctor is at the top of the food chain is that people below that level feel more anxious or don't feel empowered to raise concerns that they've got. When you get the leadership right, a big part of really good leadership and sort of trial quad leadership is that the messaging is very different to that, and it feels much flatter to people, and they feel much more empowered to raise their concerns, and they've got a sort of clear channel in to have those conversations.
Echoes with my experience. I remember as a young business manager working, so I was working across a number of different surgical departments. There were some consultants who treated me as a peer, and we would have, different perspectives, and we'd work together. How you felt and your contribution there was radically different. It was only one or two consultants who were very much of the old, I'm the expert, I know best, your job, you're the administrator, and you should do exactly what I tell you to do. And it felt very, very different. And as you say, if you've talked about psychological safety and the ability to speak up and bring a different perspective, would vary hugely. So, and if that was true for, a relatively assertive young manager like me, I can imagine for a nurse or even a ward sister or ward manager, you'll feel very different about how you can make a contribution.
Yeah, I agree. And it's not just a safety issue and a speaking up issue. It's also we're all dealing with really wicked complex problems, and you need different perspectives to be able to solve some of these problems. And thinking about it with one hat on, so as a doctor, is only going to give you a limited range of options and solutions. When you're working in a way where people do feel equal and feel able to contribute their ideas, you get a much a much broader, fuller range of options presented, and I think the ability then to solve problems that are really tricky and solve problems that have solutions that involve lots of different parts working together to fix it, you're much more likely to do that if you've got a collaborative, sort of fairly flat hierarchy in your leadership.
So, and I'm interested about how that plays at different levels through the service. So in maternity, that might be, one would hope on every labour ward shift, you've got the labour ward coordinator, might be a band 7 midwife, an obstetric registrar, supported by a consultant and colleagues working together. And then you'll have some, the quad overseeing them. And then you'll have, they may be part of a wider care group. And then you'll go all the way up to the board. So the board to ward, how does that multi-professional leadership play out, do you think, at the different levels, particularly when you get up to board level, which is where you're now working as well as a non-executive?
It's sometimes easier to have those multi-professional, multidisciplinary conversations at a higher level when you've got protected time to do it.
Yes.
When you gave the example of the maternity ward, I think you often see the midwifery leaders taking the lead on a labour ward because they're there. The doctors are being pulled off to go and do operations, They may be covering gynecology as well, for example. So you don't have that necessarily same consistent presence on the ward like you do from midwifery leadership, and that can be a problem. And that's why it works at its best when people have taken the time to build trusted relationships outside of the context of the fires they're having to fight. I think the pressures on the medical workforce and the fact that they're pulled in lots of different directions makes it a bit more difficult, which is why you've got to do a lot of work to build effective relationships so that you can be on the same page even when you're not physically able to spend as much time together as you like in the context of the ward. How does it work up through the different layers? I guess thinking at the other end at board level, my experience at board is that I've seen it work really well actually, and that's because when you get to board, all the executives are largely seen as equal in the context I've worked in, and that's really helpful. I do think that it's really important that your chief nurse and your chief medical officer collectively share responsibility for quality and safety. And sometimes there's a risk, and I've seen it in a number of different organizations, not just acute trusts, but in systems as well. A lot of the time, quality and safety ends up being passed to nursing leaders, and it's not seen as particularly sexy, maybe. So the doctors don't rush after it, and also there's a lot of risk in there, so no one's sort of chomping at the bit to take on more responsibility for quality and safety necessarily. I think when it works really well, your medical, your nursing, and your managerial leadership collectively share that responsibility for quality and safety and take it really seriously, that then it can work effectively, because you need the doctors to be as concerned about whether someone's had their venous thromboembolism assessment, whether they're at risk of falling, as you do the nursing team. It's got to be shared responsibility for some of this basic stuff.
And shared responsibility and clarity of decision making and accountability. And obviously the operating model is trying to make, as you said at the beginning, give us that clarity. So how do we always make sure we've got really clear decision making rights and accountability, and we're saying it needs to be shared for some of these core bits? Do you see a tension in there sometimes, or is that just something that necessarily requires time to work it through and make sure you've got relationships and trust and you know how to work together?
I think it is really tricky. I do think it's really tricky thinking about shared responsibility, but real clarity around decision making. I don't think they're mutually exclusive. So I think we can all feel equally responsible for particular elements of patient care or safety, but be really clear about whose job it is to do what.
Yeah, yeah.
And I think that's what you're getting at when you say an effective operating model.
Yes. Yeah. And effective enough that it works. It'll work with different characters, but also, as you said earlier, creates the time and the space so people can build relationship. Because however good you write things down, without relationship, I think you're going to run into challenges.
I mean, a good example would be theatre safety. So, your pre-operative checklist, your post-operative checklist, counting your swabs in and out of a patient. You need to be crystal clear who's responsible for doing the count, but you need everyone in the room to feel like it is really important, so that there's no pressure on the person doing it to do it more quickly or to cut corners. And if it goes wrong, you need everyone in the room to think together about where it went wrong, not to blame the person whose job it was to do the count. And you also need a culture where it's supportive and where people feel empowered to raise concerns if it's difficult to do what they're being asked to do. So if there's a time pressure or a reason why it's hard for them to do some of those basic stuff, then everyone needs to feel empowered to raise concerns about that. So I think that's the relationship bit and the culture and the psychological safety element of effective working. And sometimes when you think about an operating model, you think about the structures and the decision making, but a key part of an effective operating model is also how you set the right culture and how you make sure there's psychological safety.
Yeah, absolutely. Absolutely. I think, and creating a leadership system that means you've got leaders who understand and know how to start creating the right conditions for psychological safety, for strong relational kind of practice is really important. So because it's not necessarily natural to everybody, because people have often coming together, trained in many different cultures and institutions. So And do you think, the development of the culture, the attention to the organizational culture and the attention to the operating model kind of need to be linked in some way? In your experience, when it's being talked about at the board, are they thought about in an integrated way, or is there a danger we say, oh, that's a problem over there, or that's a problem over there? What's your experience?
And I think there's a risk that pieces of work around organizational structure are done separately to pieces of work around organizational culture, and having a joined up way of thinking about that, and making sure that even if they're slightly separate pieces of work, they're done together and are aligned is really key. I
And
mean,
I'm interested because now,
yeah,
and it may be moving to a slightly different place in that your obviously your background as a GP and as a system leader, it's not you're not quite gamekeeper turned poacher, but as somebody who'd have a perspective on provider trust, and now you're involved, in board leadership. What did that GP system leader perspective give you on of the trust, and then what have you found when you're in there? What's changed in how you've seen the world and the way, particularly, it's organised to get things done?
I think when you're sitting outside an organization, it's easy to feel frustrated when you look at it and things
Yeah,
don't work as they should. Once you're inside an organization, you understand the challenges that people are working with and the level of complexity, and how things that look like they should be easy to fix are actually much more difficult. I think it's helped me understand why there are problems, particularly at the primary secondary care interface, which is, I think, one of the biggest challenges we have in health systems. And that's why where I've seen clinical transformation at its most effective, I've seen it co-led, so secondary and primary care leadership. And I don't just mean doctors. When we had effective clinical networks in Southwest London, it was about having someone from secondary care and someone from primary care who understands those, who have the understanding of those different worlds coming together.
yeah,
Pharmacy leadership from primary care, for example, we had nursing leadership from secondary care. But the key thing is you fundamentally think about things differently. Part of it is around risk, so very different concepts of risk, and also just an understanding of what is possible in those two different worlds. And I think unless you inhabit those worlds, you don't really have that full understanding of what can and can't be done, and why things might be tricky. So I've seen it work really effective when you get leaders from those two different spheres come together around a problem or a pathway and work on it together. First of all, you see the relationship build, and you see those sort of light bulb moments as they start to understand the other world. But then you also see really effective problem solving going on.
and so in the point of view of somebody designing an operating model for a acute trust, thinking about how you deliberately design your interfaces and your connections and into primary care and the community feel like there must be an important part of the solution that you come up with.
Well, if you're thinking about what's best for your patients,
Yeah,
then it absolutely would be. And if you're thinking, if we can all, in whatever organization we're in,
yeah,
get into the mindset that ultimately we're in the business of doing the best thing for our population, then of course you would want to make sure that your discharge arrangements, your interface with primary care, the way you do outpatients is the best thing for the patient. And that involves, it means that your service needs to be really well integrated. And of course, there's a huge amount of movement now and pressure to integrate more effectively. The whole hospital to community shift is not just turfing stuff into the community, it's fundamentally signaling a different way of working that has to be more integrated. I don't think you're just going to move activity around, you're going to have to move people around, and you're going to need to be moving it, working in a different way. So I think historically, it's been very easy as a hospital just to think about what goes on within the boundaries of your hospital. That the world has changed, and we have to get into a different mindset.
and you beginning to see change there? Is that
I think at organizational level, leaders understand that now. And I think the system conversations are different. I think the internal conversations in trusts are different, particularly with the focus on neighborhoods and the idea that you're going to need place integrators. And a lot of big trusts are thinking that might be a role they should be taking because they have the infrastructure. Well, they also need to take the time to understand what they're getting into, because place is complicated. So you need people who live and breathe and work in place to be part of the leadership of trusts and part of the leadership of development programs and transformation involved in building that different approach to healthcare.
Yeah. And so we might say the operating model for neighbourhood-based care systems is actually going to be really quite different from what people might have been used to in an acute setting. Because as you say, if you took the shared responsibility but clarity of who's doing what, becomes even more of I think, an acute challenge, because people will work to many different organisations who are working in, integrated neighbourhood teams.
It's going to require really good leadership to make this happen, because every department, every clinician working in those departments needs to fundamentally understand the direction we're moving in and how it needs to shift. People need to understand that when they become a hospital consultant, they might not just be working in a hospital.
Yes.
Their job might actually involve supporting neighbourhood management of patients who historically would have come into outpatient clinics or been admitted to a ward. Now your responsibility for those patients doesn't end whether at the front door of the hospital or the back door of the hospital. It's going to need to continue into caring for them in a neighbourhood context.
I mean, I think for many people that could be very exciting in terms of the ability to influence outcomes and the kind of whole population health. If that's your motivation as a clinician, which I'm sure it is for many, it's quite exciting because you can influence things you never could before just within the hospital.
I think it could be really exciting, and for some it will be. I think it can also be frightening. And
Right.
I think it gets back to one of the things I touched on before, which is the concept of risk and who's responsible for a resident or a patient, depending on where they are. And that's been one of the really interesting things, having worked in both general practice and
Yeah.
being on the board of a hospital and having all those internal conversations at hospital, because I'm chair of the quality committee. There's historically a mindset in hospital that the safest place for a patient is in hospital and in a hospital bed. And when you work in the community, you don't necessarily believe that, and you can see it's not always true. I think the historical approach to risk from a hospital clinician is to minimize the risk, let's get them into hospital, and I then know I'm responsible for them and I can control every bit of their care. We have to change that, because actually in many cases the best place for a person is in their own home, and there will be some stuff we can't control, but we can mitigate and manage those risks. And as a primary care clinician, I feel comfortable with that, but if I was working in a hospital, I would perhaps intrinsically feel less comfortable with it unless I really started to understand how it felt to work in a community setting, and I'd been and visited patients in their own home and understand what's possible and how you deal with some of these issues.
And that's going to take again, it needs time. Do we need to give time for some of our consultants to go and spend time working in the community and doing home visits and things like that? Or is that, because obviously you're in mid-career and you've got great expertise in your particular area based on secondary care historically in a hospital setting. That shift of perspective must be really hard for people who are 20, 30 plus years into that career.
I would think so, and I think unsettling.
Yeah. Have you seen examples where it's worked? I mean, because I always hear about a few, a rheumatologist or a respiratory consultant who did start working in the community and they made a great difference, but it's kind of like not routine. You hear those stories.
It's not routine, but there are brilliant examples.
Yes.
And I've seen so many examples, even in
Right.
South London, of interface services. I mean, particularly things like interface geriatrics, where
Right.
the consultants, I mean, they come into the job expecting to work across sectors, and they're therefore very comfortable with it. But I've seen in Southwest London, for example, we've got a urologist, consultant urologist, who is leading a clinical network with one of our GPs. And I mean, part of it, Alastair, is taking the time to build those relationships and understand each other, which I saw them do. I hear that the consultant's gone out with the GP in their own time to a local church to talk to people about prostate cancer screening and what they should be aware of, because they start to understand how important some of this stuff is. So I think there's brilliant stuff happening, but it's just not the norm, is it?
Yeah. Yeah. Well, maybe we're at that time where that overall expectation, the kind of paradigm is changing. the NHS 10-year plan is a 10-year plan. Maybe it'll be interesting whether in 3-5 years time it feels like we've made a significant shift, and in 10 years time it'll feel like it's a very different, and the new paradigm is much more the kind of Claire Fuller neighbourhood based teams, and the hospital is only when you really need it, and the resources are and expertise is being deployed into the community on a routine basis. So yeah, I think I'm just intrigued how the operating models of today need to facilitate and set up to make it easier for clinical colleagues to make this transition over time, managing risk and trying to manage clarity of who's responsible for what through it all. So that's
yeah. And I mean that is what we need to do, and I think there's all sorts of good work we can do on structuring that, and thinking about the culture you need to deliver that. The starting point for me, where I've seen it work most successfully, is the relationship building.
Yeah.
And I remember when I started as a GP back in 2004, we did have more time in our day, and there were more opportunities to interface with hospital consultants. And even then I would refer to hospital consultants by name. I'd pick which one I wanted to refer to for what. That's gone. The world has changed. You refer now through advice and guidance to a particular service a lot of the time. Everyone's working lives are busier and rushed. You're squeezing admin in. There's less time for conversations and relationship building. And I think however we structure things, we have to build back in the time for dialogue about patients, about service change, and building those trusted relationships, because that's where I've seen the clinical networks work really effectively in Southwest London. The most important thing has been you put them in a room together and they have some time together and they start to build those relationships and trust, and then everything else springs from there. You almost don't have to over engineer it. Clinicians want to make things better for their patients, and they want to do it in the right way. If you just give them time and a framework within which to work, you can sort of in some ways let them get on with it, and you'll be surprised about what they can deliver if you just take some of the shackles off.
Well, that's a really good place to finish, because in a sense I hear, let's make sure whatever the operating model, the structure we create, is enabling and not constraining. And ultimately people want to do the best they can, and that's what we've got to enable. And there's a danger of, as you say, over engineering, so it becomes a constraint. So
yeah. I agree. Simpler the better.
Yes, absolutely. Brilliant. Thank you so much for your time, Andrew. That's been really enlightening. I am